Well, thank you. Thanks for the invitation. Um, I actually have enjoyed, I've come out to Ames a couple of times to do talks, and I've actually enjoyed my drive out there. I was really glad one of our fellows actually went out there, Lindsay Reari, and she's joined you guys out there. So we're very pleased to have her stick around in the region. So I'm going to talk a little bit about procalcitonin. We'll talk a little bit about the science behind it. Those are my disclosures, and sort of what makes it go up and down as a biomarker. We'll talk about how it can help us in our antibiotic decision making, and then we'll talk a little bit about at the end how it can help us with COVID, or maybe not help us. And so we'll talk a little bit about its relation to COVID, because everything is COVID now, and I just appreciate not having to talk about COVID for once, which is great. So this is a case that I saw a few years ago. 30-year-old male with diabetes, had fever, cough, chills, nausea, vomiting, body aches for 3 days. He literally said it felt like a truck ran over him. His white count was normal. His lactic acid was normal. His chest x-ray showed some bibasilar pulmonary fasciitis, maybe developing consolidations. And his rapid flu is positive 4B. And so the question is, would you start antibiotics on this patient? And that's a question where some people would say, boy, it sounds like flu. I wouldn't. And others would say, boy, I probably would. And some would say, I'm not sure. And maybe we do some other testing to try and sort it out. The CAP guidelines would say we should start everybody on antibiotics who has pneumonia and flu. But his procalcitonin is 0.75. And so we elected to start him on antibiotics. And overnight, he grew group A strep in his blood. And actually, he got better relatively quickly after starting antibiotics. But it was a serious infection. And other than his procalcitonin, he didn't have any strong markers of bacterial infection. And so this is just a case sort of illustrate where procalcitonin, I think, could be useful. The problem we have is antibiotic use isn't optimal. I'm sure you guys have heard many people talk about this, but there's a lot of inappropriate antibiotic use out there, results in resistance, results in toxicity, renal dysfunction, results in C. diff. I don't want to belabor that. But why do we use so much antibiotics? Well, the reason is it's actually hard to make a diagnosis of infection. If you look at sepsis, the gold standard for sepsis diagnosis is really I gave them antibiotics and thought they had sepsis and they got better. Cultures only determine an etiology less than half the time, and most of the cultures are negative or grow contaminants. In pneumonia, another example, diagnosis is very difficult. The etiology of pneumonia in the most aggressive diagnostic studies out there only find the etiology about half the time. Blood cultures have such low yield, they're not recommended even, except in severe CAP. Sputum cultures and gram stain, almost half the people can't produce sputum. And once you start antibiotics, the yield of those sputum cultures drops off rapidly. And so, that's why we overuse antibiotics, because it's hard to sort out whether people have infections or not. And so that's where biomarkers come in. And so biomarkers we use in a lot of places. They're measurable characteristics to reflect the severity of presence of some disease state. And we use biomarkers right now. We use fever, we use white blood cell count, we use CRP. Now, the ideal biomarker would be both sensitive, not going to miss anybody with a bacterial infection, and specific, not going to be positive in people who don't have a bacterial infection. It'd be helpful if the higher the level, the more likely it was that they were infected and the more severe the infection was. It'd be ideal if that biomarker got better when you treated the infection. And many of our biomarkers that we currently use are confounded by immunosuppression and other conditions. And then any biomarker you're going to use to sort out if someone has an infection needs to be fast, right? I don't want to wait 3 days to sort out, do I need to give antibiotics or not? By 3 days, it doesn't matter. And any test, we really need to be cheap. What I'll tell you is the ideal biomarker does not exist right now. No test is out there that checks all those boxes. Procalcitonin is the best we have right now. It's not perfect, but it's the best we have of biomarkers for bacterial infection. And I'm going to just show you some of the data to support that. So where does procalcitonin come from? Well, it's a product of the calc genes. And let me turn on my little pointer here. So there are a variety of calc genes, but when they're transcribed, they're turned into a precursor peptide and translated into precursor peptide, which eventually gets post-translationally modified in the Golgi apparatus into calcitonin. And that whole system of calcitonin production is under highly complex endocrine regulation by a bunch of hormones and things that I've forgotten because I don't do endocrinology. But it starts out as procalcitonin and then is modified into calcitonin in only a couple of places, in those C cells in the parathyroid area and a couple of neuroendocrine cells in the lung. And your normal physiologic levels of procalcitonin are on the picogram level. They're really, really low. What happens in bacterial infection is the cytokines that are released with bacterial infection, and lipopolysaccharide as well, can stimulate what's termed a hormokine production of procalcitonin. It's sort of produced constitutively all over the body, and it stimulates a variety of tissues to produce procalcitonin. It's not post-translationally modified. It's rapidly secreted directly from the Golgi. Interestingly, the cytokines produced in viral infection, like interferon gamma, tend to inhibit that as well. And that's both rapid and produced in a variety of tissues. This is a list of tissues that produce it. So this is normal physiologic state. You can see calcitonin is in the thyroid, a little bit in the lung. But under sepsis, procalcitonin is produced in a variety of tissues across the body. And so that's one of the things. You can't lose the cell or the tissues that produce procalcitonin. I mean, it's produced by visceral fat, and everybody's got lots of visceral fat. That production is ubiquitous. It's multi-hundredfold after stimulation by cytokines, and it's much more widespread than the other cytokines we might try to think about measuring. Now, it is driven by cytokine release. These are this is data generated doing lipopolysaccharide experiments where they inject lipopolysaccharide and measure cytokine and other biomarker release. You can see the other cytokines, IL-6, IL-10, TNF-alpha, rise more rapidly, but also decline very rapidly. And they're much more difficult and complicated to measure. Procalcitonin rises typically within 6 to 12 hours after an infectious insult, and then peaks, at about 20, at 6 to 12 hours there. CRP will do the same thing, but it's later. It tends to be 24 to 48 hours. And so it doesn't rise as rapidly as procalcitonin. One of the things you also need to know about procalcitonin is where does it not go up? And localized infections do not cause this. And so this really needs to be systemic cytokine release. And so localized abscess, cystitis, osteomyelitis, they don't make your procalcitonin go up. They just don't. They don't drive that systemic cytokine release like syndromes like pneumonia or sepsis do. The dynamics of procalcitonin are actually, I think, even more useful than any individual single value. One of the nice things about the dynamic is they mirror what happens physiologically in the patient. This is a study that looked at patients with neutropenia and bacteremia or severe sepsis. These are patients who responded to therapy. These are those who didn't. What you can see is those who responded to therapy, procalcitonin came down nicely. Those who didn't get better, their procalcitonin didn't go down and in fact went up. And that dynamic of non-declining or rising procalcitonin after a couple of days is actually a pretty good marker of a poor outcome. I could show you a variety of studies that demonstrate that, but this is one that I thought did it relatively well. Is a study of VAP patients, ventilator associated pneumonia. What you can see is those who survived, their procalcitonin levels from day 0 to day 4 declined very nicely. And those who didn't survive, their procalcitonins actually rose. And so that rising procalcitonin is a bad prognostic indicator. What you do with bad prognostic indicators is always a little hard for me to know. Yes, it's bad, but should I do something different? I'm not always sure. I'll talk to you a little bit later about what we can do with rising or non-declining procalcitonins. I have a couple thoughts about that besides say, well, that's not very good. So just to summarize, I could have frankly talked for about 40 minutes on what I just covered, but I tried to keep it brief. Procalcitonin is produced ubiquitously through a cytokine stimulation when there's a bacterial infection. I'm not going to show you this data, but it is the most specific biomarker for bacterial infection currently available. We'll look at a little of this, but I want to get to like the meat and potatoes of what actually happens when we use it. The levels rise rapidly within 6 to 12 hours and actually decline predictably, about 50% every 24 hours, if you've controlled and treated the infection. Now, a non-declining procalcitonin is bad, can suggest you are not adequately treating the infection, or there's something you're missing, or maybe there's resistance, or something needs to be drained. And so non-declining or rising procalcitonin doesn't make me switch my antibiotics. It doesn't make me, start doing an imaging, but it does make me reevaluate the patient. If on day 3 or 4, it's not starting to come down, it starts to make me say, I get a little nervous. And then it's not impaired by neutropenia or other immunosuppressive states. I am going to talk to you a little bit about, though, things that can make your procalcitonin go up that are not infection. And that's really important to understand when you're talking about procalcitonin. There are things that make it go up that aren't a bacterial infection. And so one of those things is actually major physiologic stress. It turns out being born is a major physiologic stress. And so neonates have elevated procalcitonin levels. They tend to go back to normal by 72 hours. But it's hard to know what they mean in the first 72 hours of life. Any sort of massive stress, a severe trauma, surgery, cardiogenic shock, CPR, all of those things are going to cause release of systemic cytokines and make your procalcitonin go up. Now, if they don't continue, it should go back down to normal over the next couple of days, declining about 50% every 24 hours. If you have prolonged non-resolving problems, like prolonged cardiogenic shock that just isn't getting better, your procalcitonin is going to go up and it's not going to go down. We had a patient who a number of years ago had 70% burns on their body. Their procalcitonin never went below 2 because they had 70% burns and a continual cytokine activation. Now, when they developed an MRSA bacteremia, their procalcitonin went up to 30. And so the dynamic was intact, but the absolute value became much less meaningful. There are some non-bacterial cytokine activation things that can happen. Certain forms of vasculitis and acute graft versus host disease can drive procalcitonin levels. Malaria and candidemia can also cause your procalcitonin to go up, often not as high. Chronic renal disease is an important one. So chronic renal disease is a generally pro-inflammatory condition. And so your CRPs will be mildly elevated. A lot of inflammatory markers will be mildly elevated in people with significant renal disease. And so what do we do with procalcitonin levels? Well, what we've found is that low levels still mean something. If it's still really low, it's really low. If it's really high, that still means something. If it's in the range of 0.25 to 0.75 or 1, it's a little hard to interpret what that means. And that's where the trend can be more meaningful. Because of that low level inflammation, it's just a bit harder to interpret. But low, still useful, below 0.25. Over 1, I think still useful as well. And then there are some dysregulated procalcitonin syndromes where you can have cytokine stimulation through some of our induction agents for organ transplant or paraneoplastic syndromes where you produce procalcitonin. And so it's important to understand this, particularly when you're managing ICU patients is where you encounter a lot of these, because those can confound how you interpret this. And so important to understand those. So, are we going to look at any diagnostic studies? We are not. I'm not going to show you sensitivity and specificity. I'm not going to show you positive and negative predictive value. Those are all the observational trials, right? There's like 100 of them probably, if not more, probably hundreds looking at different conditions. I'm not going to show you any of the at least 6, maybe 7 now, I haven't checked recently, meta-analysis looking at the performance of procalcitonin. The reason I'm not going to do that is because those are good evidence foundationally, but they don't really tell us how procalcitonin performs because there's lots of issues. We've already talked about the gold standard. The gold standard is not good at sorting out infection. And so we're using a biomarker to sort out bacterial infection with a poor gold standard, hard to interpret. There are a lot of different cutoffs in those studies. Some of them use different assays. There's a whole variety of clinical settings, and then there's a huge selection bias. Because you said that typically the ways these are done is you say, well, I'm going to take 100 bacteremia patients and measure a biomarker level in them. Well, does that really help me make decisions? It really doesn't actually, because I don't evaluate 100 patients with bacteremia. I evaluate 100 patients who might have bacteremia. And so really what I want to know, how does that marker perform in patients who might have bacteremia? And is it clinically useful? Does it change how I manage patients? And if it does, is that good for patients? And so that's where we really need randomized controlled trials where we randomize patients to usual care versus care that's helped with a biomarker. And the good news is we have a host of randomized trials, more randomized trials than frankly I know of any other diagnostic marker. There may be some in cardiology. I don't know that literature as well. And frankly, I don't read the cardiology literature. But in ID, we don't have anything like this. And then there are actually a variety of meta-analyses of all those randomized trials. And that's what I'm demonstrating here with this quality of evidence scale. But really the question is, How do patients do when I use this to make clinical decisions? That's really the gold standard for how good a diagnostic marker is. And so I'm not going to talk about the observational study. I'm not going to talk about the meta-analyses. I'm really going to talk about where the rubber meets the road. What happens when I use procalcitonin to manage patients? Excuse me. I'm going to focus on respiratory tract syndromes and septic shock and severe sepsis. That's where most of the literature is. There's literature in a variety of other conditions. Meningitis, pancreatitis, heart failure, interestingly, pyelonephritis, particularly in kids, postoperative infections. But I'm going to focus on those couple of conditions. This is a first randomized trial done in procalcitonin. What they did was a single center, randomized, single-blinded trial where they took patients in the ED who presented with lower respiratory tract infection, pneumonia, bronchitis, a variety of other things, and they randomized them to usual care. You do what you're going to do, or we're going to measure procalcitonin, and if it's more than 0.25, we're going to recommend antibiotics. If it's more than 0.5, we're really going to strongly recommend them. If it's less than 0.25, we're going to say, don't really need antibiotics. If it's less than 0.1, we're going to say, yeah, we really don't think you need to do that. If antibiotics weren't started, they repeated the procalcitonin 6 to 24 hours later, and they allowed physician overruling, which is important because we treat patients not lab values. And so in this study, it was about 18%. 18% of times, the physician didn't follow basically the guidance from what the biomarker said, which is okay. They're a decision aid. They're not the gold standard for how we treat people. What was the outcome? Well, the key outcome was they saw a significant decrease in antibiotic use, and they didn't kill a bunch of people. Right? We know we overuse antibiotics. So the question is, can we safely decrease using antibiotics and not harm people? And so that's what this table shows, is that mortality was no different. Days admitted was no different. Antibiotic prescribed and antibiotic use per 1,000 patient days declined by almost half. Now, where was the biggest bang for the buck? Well, it was in a lot of conditions where we know antibiotics aren't as useful. Exacerbations of chronic bronchitis, asthma. These conditions are often just caused by viruses and don't need antibiotics. And so that's where they got the biggest bang for their buck. But even in community-acquired pneumonia, they decreased antibiotic initiation. And, if you look at the literature, there's a lot of viral pneumonias out there. If you read the New England Journal CAP study, viral pathogens were 6 of the top 7 pathogens isolated from patients with CAP. And people always talk about, well, is this bacterial co-infection? Well, I think this is a tool for helping us sort that out. So, a variety of other trials were done after that. This is the largest randomized trial looking at procalcitonin use. I'd point out it was done more than a decade ago as a multicenter non-inferiority randomized trial looking at same population, lower respiratory tract infections in the E presenting to the ED, most of which got admitted. What was different about this study was not what they recommended for starting or stopping antibiotics, but they did serial procalcitonins where they did them again at day 3, 5, and 7. And if the level dropped below 0.25 or 80% of the peak, they recommended discontinuing the antibiotic. So not only looking at antibiotic initiation, but also looking at, can we discontinue antibiotics earlier? And the answer was, looked like we could. Compliance was better in this study, 91%. Antibiotic exposure overall declined by about 35%. It varied by syndrome. It was about 65% in COPD and about 30% in CAP. And so the biggest difference was in that COPD bronchitis group. Antibiotic prescription rate declined somewhat, about 12% overall. Mean antibiotic exposure decreased from about 9 days to just under 6 days. So they cut the duration of antibiotics significantly. Were there adverse outcomes for giving less antibiotics to people? The answer was no. 30-day adverse outcomes were actually lower, and antibiotic adverse outcomes were significantly lower in the procalcitonin group. Not surprising, less antibiotics means less antibiotic side effects. And again, no mortality difference. And then this is the most recent and I think the best meta-analysis of procalcitonin and lower respiratory tract infection. This is a patient-level meta-analysis. And what's different about a patient-level meta-analysis is you take the individual patient data rather than the composite study data, and you combine all that. They had 6,700 patients, all in randomized trials, 26 trials, 12 countries, mostly Europe, I would say. Variety of respiratory tract sections. So it was a very diverse group. Almost half CAP, with a smattering of HAP and VAP, some bronchitis, COPD exacerbation, most of it in the ED and ICU, but some clinic setting as well. The overall outcome for this was antibiotic duration was decreased from 8 days to about 5.5. You can see over the course of 14 days how that played out. The interesting thing I thought about this meta-analysis was not only was there less antibiotic use, but mortality was actually lower in the procalcitonin group. Treatment failure was not statistically lower, but pretty close to statistically lower in the procalcitonin group. Length of hospital stay was no different. Antibiotic-related side effects were significantly decreased. So why would procalcitonin use improve mortality, maybe improve treatment failure? Well, I think we know one size doesn't always fit all. Some people are just fine with 3 to 5 days of antibiotics. Some people might need more like 7 to 10, depending on how sick they are. Also, if you think a patient has pneumonia and give them antibiotics and fluids, and it turns out they have heart failure, we're not actually helping them. We're probably harming them. There's an interesting study that looked at the assault load of patients who got antibiotics for their heart failure. And what they found is that they actually required nearly 100 milligrams more of Lasix during their hospital stay and spent an actual couple extra days in the hospital because they were treating heart failure with antibiotics, which contain a bunch of sodium. So I think that's a couple of things. They sort of, boy, the procal's low. Is this really bacterial pneumonia? Maybe it's something else. Is it that we need to be more customized? I think it's a mix of those things, but I don't think it's totally well worked out. But either way, certainly seems to be safe, if not perhaps advantageous. These are the algorithms we use at our center, just like those ones from the PRORATA study. Anything over 0.25, we recommend antibiotics. Below, we say withhold unless, they're really sick, and then we're not going to get bent out of shape if you're going to give antibiotics. Follow-up, again, we use same rules, less than 0.25 stop. If it's, not declining, we kind of talked a little bit about this. This is where we say, boy, wouldn't routinely escalate, but reevaluate the patient. Are we missing something? So, just to conclude this section, procalcitonin-based antimicrobial use decreases antibiotic use in lower respiratory tract infection without any signal of adverse outcomes, and a signal that suggests, boy, it may improve outcomes to do that. That impact is really going to vary, though, whether you're doing that in the ICU versus the outpatient setting, you're doing it for CAP versus COPD, you're going to get a different bang for your buck with procalcitonin, depending on which group you're using it in. And at the end of this, I'm going to highlight a group where it may not have much benefit at all. All right, let's move on and talk about sepsis. So these are my sepsis Venn diagrams. I still include the old sepsis diagram. The problem is sepsis is, they have, it used to be they have SIRS and I think they have an infection. Now they have an infection and they're, have some organ dysfunction. And I like that definition actually better, but it's still pretty non-specific because, the one subjective component, there's only one subjective component in the entire sepsis definition. And it's actually the most important thing. Do they have an infection? And it's often the hardest thing to sort out. Everything else is numbers, right? You can score the SOFA score. It's all just cranking the numbers. What's their blood pressure? What's their renal function? What's their platelets? But do they have an infection or not? It's actually difficult to know. So we give antibiotics. That's what we do. We don't want to be wrong. These patients are very sick. And so we give antibiotics knowing we're going to treat people who don't have an infection with antibiotics. And we're going to wait until the cultures come back and we sort of sort things out 2 to 3 days later before we stop anything. And all that does lead to toxicity and problems. So we need some tools to help us with those antibiotic decisions. So again, procalcitonin, I think, is a tool here. I would say the data is a little different than lower respiratory tract infections. I'll go through it. So there are randomized trials looking at using procalcitonin to decide on antibiotic initiation in sepsis. This is the largest one, the PRORATA trial. In this, one thing I'd point out is they used a cutoff of 0.5. Over 0.5, recommend antibiotics. Below 0.5, withhold. Why did they use 0.5? Before the randomized trials of treatment, there were numerous diagnostic studies for sepsis. And that was actually the original approval for procalcitonin was diagnosis of sepsis with a cutoff of 0.5. And so 0.5 makes some sense in the ICU because there is just a little bit more of inflammatory noise there. People are sicker, all the sort of inflammatory markers are a bit higher. And so using 0.5 improves the specificity of the test without hopefully degrading the sensitivity too much. In this trial, using this algorithm on initiation and then on discontinuation, overall antibiotic exposures over 30 days decreased about 3 days. There was no difference in mortality. Adherence was pretty poor, though, only about 50%. And you can see this is the diagram for percent of patients on antibiotics. Had some benefit, but not a humongous benefit, particularly with initiation. Almost everybody got started on antibiotics anyway. So this was, I think, the most recent randomized trial, and I really like this trial because in this trial they didn't look at procalcitonin for antibiotic initiation, because I think it's hard to sell a critical care physician on not giving antibiotics to a really sick patient. It's hard not to do that. I understand. And so what they looked at in this study was actually early Procalcitonin-guided discontinuation. So in this trial, they enrolled patients who were going to the ICU with sepsis, presumed sepsis, and then they measured procalcitonin serially. And when they got below 0.5, or they decreased 80% from a peak, they basically said, hey, you should stop antibiotics. And so the idea was, we're going to start, but we're going to try and stop much earlier, because we do tend to give antibiotics in the ICU and the patient gets better, and we don't want to rock the boat and say, well, let's just give 5 days or 7 days. I don't know this is an infection, but we'll just finish out because they're getting better. So I've heard that many times. Let's just not rock the boat. What's also important about this trial is it was done in the Netherlands. Why is that important? That's important because many of the criticisms of some of the ICU trials have been they were done in ICUs where antibiotic use was already excessive or prolonged. And if we just not given 14 days of antibiotics and only given 7 days, we wouldn't have seen much utility to this. And so what you need to know about the Dutch is they may be somewhat progressive in their social values, but they're very conservative in their antibiotic use. And that they use short courses, and they use not very broad spectrum antibiotics. They're very conservative with antibiotics, probably one of the most conservative countries in Europe with antibiotics, more conservative than the US by far. And so they had these ICU patients with presumed infection with low baseline use. So they randomized them to this early stopping. What did they find when they did that? So it's a very large trial, over 1,500 patients enrolled. So they decreased antibiotic use. Median duration of therapy in the standard of care was 7 days. Standard in Dutch ICUs, 7 days. They were actually able to decrease it to 5 days, so avoided 2 days of antibiotic use. I see it. The interesting thing again in this study, mortality was actually lower in the procalcitonin group again. Length of stay wasn't any different. So the conclusion from this study is using procalcitonin as an early discontinuation aid in sepsis will decrease antibiotic use. And boy, it may be good for the patients too. Other studies there hasn't been another large trial like this, but I don't know of a lot of diagnostic marker studies and ID where utilizing them actually helps to decrease mortality. So again, I think this is pretty strong data. There's been a meta-analysis of this, procalcitonin-guided antibiotic discontinuation. This was patients randomized to antibiotic de-escalation versus usual care. Now, some of this was taking chunks out of other trials. There were both initiation and discontinuation. This is the Dutch trial that I'm showing you here. It was the largest trial, had the greatest weight. But what they found is it did decrease antibiotics. But it was a very mixed outcome. Interestingly, adherence didn't influence the outcome. The Dutch trial had about 90% adherence at 24 hours to discontinuation. And so I think there's relatively decent data that using procalcitonin to stop antibiotics is a safe strategy. These are our algorithms for initiation of antibiotics. We use this 0.5, but we have this big red box that says, hey, if you think they might have an infection, yeah, you just go ahead and start antibiotics, and we'll sort it out afterwards. Now, a strategy I've done is sometimes you'll have patients, you're like, kind of on the border. I don't think this is infection. I'm a little concerned. I'll measure a procalcitonin and then come back 6 hours later, 8 hours later, repeat it. The procalcitonin is not rising. Boy, I feel really comfortable not initiating antibiotics and just monitoring things. If it's rising, which generally it will be if there's an infection present, then we'll go ahead and start antibiotics. So that's sort of an individualized patient decision you have to make. based on knowing the patient and severity of illness and things like that. But I've definitely done that in my practice. And then stopping again, 0.5, drop by 80% from peak, we'd recommend stopping the antibiotics. So there are some issues with the sepsis studies. A lot of them have high rates of overruling. They are somewhat selective. The renal dysfunction does play a role with some of these, but it appears to be safe, and particularly when you're using it for just discontinuing early. And so patients where the PCT values are normalized or decreased significantly, we should really think about just stopping the antibiotics, not de-escalating, not just stopping the Vanco, but just stopping the antibiotics. So when is procalcitonin less useful? This is the largest US randomized trial. It was actually a negative trial for procalcitonin. In this US trial, they looked at lower respiratory tract infections in 14 hospitals who not previously utilized procalcitonin. And they implemented procalcitonin using sort of a QI process, did some education, did it somewhat similar to what the European studies did, and they randomized to either Procalcitonin-guided or usual care. They enrolled, again, almost 1,700 patients. Interestingly, about half were hospitalized. Now, that is somewhat important because in the European trials, it was about 70% were hospitalized in their lower respiratory tract infection trials. They enrolled mostly COPD and acute bronchitis and only about 20% CAP, where what you saw was in those European trials is about half CAP or more. And 90% of patients had a low procalcitonin value, suggesting that they didn't need antibiotics at all. What did they find when they randomized patients? They found there was no difference in antibiotic use. Procalcitonin didn't decrease antibiotic use. Now, what I'll point out is the usual care antibiotic duration was 4 days. And so that's a really short course of antibiotics. And so this is one place where I think procalcitonin isn't useful. If you already are using short courses of antibiotics, you're not treating more than 5 days, you're not aggressively treating your COPD exacerbations, your acute bronchitis with antibiotics, you're not giving, 90% of those aren't getting antibiotics, yeah, procalcitonin is not going to help much. It's just, if you're already doing a really good job with antibiotics, you don't really need a biomarker to help you with that. But my experience is, well, that's not how it runs at a lot of places. My experience is people will give 5 days in the hospital, and then on discharge, they'll give another 5 to 7 days of discharge antibiotics, which really aren't needed. And we're not the only facility. I just read a paper from Hopkins where that happens at Hopkins too. So let's move on and talk about procalcitonin and COVID. We're actually just talking about this in our stewardship group today. I put a disclaimer in here. I actually haven't reviewed the literature in 4 weeks. And so there are probably 20 new papers on this topic because that's how fast literature moves on COVID. But this was about 4 weeks ago, looking at procalcitonin role in COVID infections. Generally, the values are low. That's been the consistent finding from China, from New York. The median PCT value in 5,700 COVID-19 cases in New York City was 0.2. And generally range 0.1 to 0.6. Now, as opposed to CRP, which is usually pretty high. For some reason, CRP goes up in coronavirus infection. I don't know why, but it does. Procalcitonin doesn't seem to go up in the same way. Now, procalcitonin values do seem to vary by severity of illness, and there does seem to be some prognostic utility in procalcitonin. These are procalcitonin values in hospitalized patients with COVID, and what you can see is those who died in the blue and those who survived are in the orange. Those who survived were much more likely to have low procalcitonins, and those who died were more likely to have elevated procalcitonin. Does that mean they had bacterial co-infection? Does that mean it was just all from bad COVID? Well, we don't really know that answer to that question right now, but I'm going to show you a little more data. So there's another study that looked at procalcitonin in COVID. Patients with moderate illness, procalcitonin is generally very low. As you became more severely ill, procalcitonins rose. In patients who were discharged, procalcitonins declined over the course of their illness. In those who had initially elevated procalcitonins, they eventually slowly discharged. In those who died, this is the typical procalcitonin curve of somebody who's going to die. It's a bad prognostic sign in bacterial infection. It appears rising procalcitonin is a bad prognostic sign in coronavirus infection as well. there have already, and this is what amazed me when I looked in this, there are already multiple meta-analyses on this topic of procalcitonin levels and other biomarkers predicting outcomes, which just shows you how quickly this literature is moving. This is a meta-analysis of 45 studies of 4,200 patients. What they found is an elevated procalcitonin predicted ICU admission, but not ARDS or mortality. And an elevated procalcitonin just meant the center said it was elevated. And so you can see this nice sort of meta-regression curve here with, ICU admission rate increasing steadily as percentage of patients with elevated procalcitonin increased. This is another meta-analysis looking at a slightly different set of studies where elevated procalcitonin was associated with poor outcomes, including a composite poor outcome of mortality, severe disease, and ICU. And particularly a procalcitonin of 0.5 or greater was actually the best predictor of poor outcomes. It was better than CRP or some of the other markers. So what biomarker should you be using to predict? I don't know. I think you should pick one for your center and stick with it. I think procalcitonin has some utility, although prognostic stuff is always hard to know what to do with. But it does seem elevated procalcitonin is a bad sign in COVID. Suggests you're going to have a bad course. What about empiric antibacterial therapy in COVID? This is a really interesting study. It was a multi-center study in Michigan. Looked at 1,700 patients hospitalized with COVID. They evaluated early antibiotic use and bacterial co-infection. Over half of patients got antibiotics, and infection was defined in about 3.5%. They looked at predictors. There weren't any great predictors of bacterial infection. Being older, being from a long-term care facility, having a low BMI, having kidney disease, severe illness, or higher Y count all predicted bacterial infections, which would kind of be generally good predictors of bacterial infection. In most cases, they had procalcitonins in 900 of the 1,700 patients. And actually the best predictor of bacterial infection of all their markers was a procal of greater than 0.5. Had a relative risk of almost 5. And so elevated procalcitonin, particularly over 0.5, seems to be a decent marker. Now, 20% of patients with an elevated procal over 0.5 didn't have a bacterial infection defined. Does that mean they didn't have one? I don't know. We don't do a great job of defining that. And those with the procal of less than 0.1, negative predictive value of 98% for bacterial infection. And so can we use procalcitonin as a hard and fast marker for who we should give antibiotics to? I think it's hard to say that. What we generally recommend is that the procal is low, less than 0.1, and they're positive for COVID, you don't really need antibiotics. If it's greater than 0.5, I'm not going to argue with giving a couple of days of antibiotics, getting some cultures, trying to sort it out, training the procalcitonin. If it's in the 0.1 to 0.5, it's really hard to know what to say. And we have had patients where they initially were low, and then about day or 5, their COVID worsened, and they ended up in the ICU, and their procal went up into the 1 range. And as far as we can find, they don't have bacterial infection. And so maybe it's this sort of cytokine storm, whether that's a real thing or not that's driving this, hard to know. But I think this can be a somewhat useful biomarker, although I'd say we're still sorting out how useful it is in COVID. But I think the low, the high, and the dynamic still seem to be somewhat useful, but you just have to take it into each individual patient. So hopefully I've sort of danced around that enough, but given you at least some picture of what that literature looks like. So if you're thinking about using procalcitonin, I think it helps to have somebody who knows how to interpret it. You should have some recommendations of what to do with it. You should encourage people to use it where it's useful and don't use it where it's not. We actually review patients who have low procalcitonins and are on antibiotics. And if you have a low procalcitonin and are on antibiotic for UTI, I don't know what that means. I don't know what procalcitonin means in a UTI. Can you stop antibiotics? I don't know. There are some interesting, preliminary studies looking at that, but I just don't really have a recommendation of what to do with cystitis and procalcitonins. And so there's not really a reason to measure it. It's data we're not going to make any decisions based on. And so what I usually tell our residents and fellows, if you're not going to do anything with the data, why obtain it? want to make sure that if you're using it, it shows up where people evaluate infection. So we actually have a little a report where we have the fever curve and the white blood cell count and the procalcitonin and the antibiotics and the culture results, and they all live in the same place because we want people to look at all of that. And then I think your stewardship team, having your stewardship team intervene can be helpful. In one study, a local stewardship team plus implementing procalcitonin algorithms actually decreased antibiotic use by 20%. In another study, they looked at community hospitals, which had procalcitonin, where the pharmacists would tend to intervene, compared to those that didn't, and they showed a decrease in length of stay and a non-significant decrease in antibiotic use. And so is that all just stewardship? Is that stewardship plus procalcitonin? Is it both? I think there is some suggestion that, it does help. This is just my experience. It helps to bump people if you want them to do something with it. It helps to just nudge and say, hey, I saw this was negative, and what are you thinking with antibiotics? So a couple of key points. The dynamics are very useful. You always have to keep in mind, though, the things that can make it go up that aren't infections. We want to use it in syndromes with data, lower respiratory tract infection, sepsis. If you aren't going to do anything with it, don't bother. You're just like wasting money. And generally, we don't test more than every 2 to 3 days. Except in the ambiguous situations where I'm like, well, am I going to really start antibiotics or not? What am I going to do? Where is this trend going? Where is this train going? And so that's I'll occasionally do one and then do another one the next day. But generally every 2 to 3 days is all that needs to be done. I wouldn't do these daily. I just don't think doing them daily. We don't usually react to daily data. We get one and we say, well, it's kind of about the same, but a little up. Am I going to do anything? Well, no, not really. Let's wait and see what it shows tomorrow. But really, we should just wait until tomorrow. So I'll finish off with just a couple of cases and then have some time for discussion. 65-year-old female recently discharged after a hospital stay for acute MI. She got stented. She comes back in with shortness of breath over the last day. She has cough, doesn't really produce much. She's hypoxic. She'd been at a rehab facility. She doesn't have fevers or chills, but her white count's up. She's got a less shift. Her lactic acid is almost 3. She's got some AKI. Chest x-ray shows some new opacities. Is it edema or pneumonia? So this is a dilemma you often run into. Is this sepsis? She's got elevated lactate, end organ dysfunction. You got to give her a bunch of fluids and broad spectrum antibiotics. Or is this heart failure with some renal hyperperfusion? Well, her Procal was 0.05. So our hospitalist team, the ED actually gave her a dose of antibiotics. Our hospitalist team saw her and said, we don't think this is infection based on the clinical picture and the procalcitonin, withheld antibiotics, gave diuretics, and she was much better the next day. Now, if they'd given her 30 mLs per kilo of fluid and a bunch of doses of Zosyn and vancomycin, she would not have been better the next day. She would have been significantly worse. So this is, I think, a scenario where it can be helpful, right? Where both a procalcitonin and maybe a CHF peptide. There's a couple of biomarkers. And frankly, I think that's where we're going to end up in infection in ID, is we're going to end up with a panel of 2 to 3 biomarkers that we're going to utilize that may include procalcitonin with some other ones to help identify better bacterial infections. What I'll tell you is we are a long ways away from that, because those studies that are being done right now are in the observational, how good, what sensitivity, specificity. Randomized trials using those are a long ways off. All right, next case. 77-year-old female with dementia, O2 dependent COPD, comes with mental status change, increased O2 need. It's COVID at the facility. She's got crackles. She's febrile. White count's normal. Hazy opacities. Procal's low. This is a patient where I personally would probably not start antibiotics. It would depend a little on how sick she was and if she was going to the ICU or not. If she wasn't going to the ICU, I personally would not start antibiotics. If I knew she had COVID, I would definitely not start antibiotics. But you don't know right now. So would it be a reasonable strategy to start, give a dose of ceftriaxone and azithromycin? The next day she's positive for COVID. A repeat Procal is still low. Stop the antibiotics. I think that's a reasonable strategy. All right. And then I always like to throw in a case where it didn't work. 29-year-old female was transferred to us. She had fevers, rash, joint pains, renal failure, headache, confusion, macular rash, synovitis, didn't have meningitis findings, white count was up, creatinine was up, urine was full of blood and white cells, inflammatory markers were high, and complements were low. And her Procal was 6.5. And so there was this question, you have meningitis, what's going on here? Something's really wrong with her. She got put on vanc and ceftriaxone. She got a huge workup. All the ID workup was negative. Her ANA was really high. We said, boy, this really looks like lupus. We'll treat her for meningitis. Rheumatology said, we don't think it's lupus, which is what they usually say. But then after a couple of days, like, well, actually, yeah, we think it is lupus. And so this turned out to be severe lupus with possible cerebritis. Now, on day 4, her Procal was still like 4.5. And if you read the literature on Procalcitonin, it's not supposed to go up in lupus. But hers did. And she looked good. We couldn't find any bacterial infection. And so we stopped the antibiotics. So I include this case to just show that you have to treat the patient, not the number. And so we're appropriately cautious. But when we couldn't find any infection, we stopped the antibiotics. So with that, I will go ahead and stop and take any questions.